So being an ophthalmologist, what are the critical steps that you will say for a kid's eye health?
First, look for any refractive error in the child. Go for an annual checkup. Any distance for the devices. Keep a particular distance for computers. Keep a particular distance for phones. And make sure your child is doing an outdoor play at least 1 hour, half an hour a day outside. Please change your glasses in those scenarios. First of all, if you have scratches and if it's an old spectacle or anything, don't wear them. It's not worth it. It's not beneficial.
Because it is putting a strain on your eye.
It's putting a strain on your eyes and it's not allowing the right light to go in.
So a patient with high sugar can actually have blood clot in the eye to leading to a complete vision
Complete
loss.
vision loss. Over a matter of seconds.
Once the retina is affected by the sugar, it is irreversible.
It's irreversible, almost. Diabetic retinopathy, glaucoma are two diseases. Once they start affecting the retina, they are irreversible.
So hypertensive retinopathy can happen if the blood pressure is more than 140 or even between 120 to 140, stage 1, stage 2 hypertension as well.
Hypertensive retinopathy can happen even in normal tension.
We'll talk about cataract.
Sure.
Cataract is very common. So what are the things that we could do to prevent cataract?
Please stop smoking. Because no matter what you do, smoking is very detrimental. Overall health, including cataracts.
Smoking is directly linked to cataract.
Directly linked to cataract, absolutely.
Alcohol?
Alcohol occasionally is okay, but excessively or doing it too frequently can both be harmful to you.
Hello, Dr. Ash. Hi again.
Thank you so much for having me.
We learned a lot on the previous episode.
Absolutely.
Okay, so now as an extension of the previous eye discussion, we want to learn more. Especially I want to learn more. That's why I brought you back again. So straight off the bat, I'm going to ask you, biggest question in everybody's mind is when to go to an ophthalmologist. Should we have to go and get it screened even when they don't have any symptoms? What will you say for that?
Amazing. So let's break it down to two segments. One is children and then you have the elderly age group. Okay. The children, 0 to 1, when the child is born, look for two simple things. First, is it a premature or an underweight baby? If it is a premature or an underweight baby, immediately you must start thinking of retinopathy of prematurity. What happens in retinopathy of prematurity is very simple. When the baby is born premature,
Which is like 3 or 4 weeks prior to the
4
delivery
weeks
date.
prior to the event of delivery date. If it happens premature, if the baby is born premature, the retina is not fully formed. So when the retina is not fully formed, the life support that is required is oxygenation. So the first thing they do is oxygenate the baby in the ICU care. When they oxygenate the baby, it triggers a response that now everything is closed, now don't form anymore. But the retina is not formed.
Wow.
So the trigger is close. So the development is stopped. Now there's a trigger of hypoxia. There's an area of no oxygen going to some parts of the retina. That triggers abnormal vessels to be formed.
I see.
These abnormal vessels will cause bleeding or pulling or traction of the retina, which will cause retinal detachment. All these is called as retinopathy of prematurity. So in order for your question, between the ages 0 to 1, at least by the time they are 6 months of age, please get one retina investigation done if that is a premature baby or an underweight baby.
Underweight is based on the growth chart.
Underweight is below 2.6 kgs or
Below 2.6 kilos.
2.2 kgs or I don't know the exact nowadays number, but
I
that's
see. It's called low birth weight.
low birth weight child.
Low birth weight. So if you have a low birth weight and if you have premature 4 weeks prior to your due date, please check with the retinal specialist between the 0 month to 1 year.
0 to 6 months.
0 to 6 months.
0 to 6 months, please check once.
Okay.
That is the first thing. Between the ages of 2 to 5, please get 2 tests done. One is of refractive error. If there is any refractive error brewing, we must know it, acknowledge and put the right glasses or prescription glasses or patching if required to prevent a condition called as lazy eye or cross-eyed, as they call it, between 2 to 5. If you have a patient with lazy eye between the ages of 2 to 5, you'll have a convergent squint. Because the medial rectus muscle is very strong, it will pull.
It's pulling across.
Versus if you have an age group of 5 to 10 with low vision in one eye, it will go for a divergent squint.
So the eyeball looks like
Looks squinted. Now there is a big myth around this. The myth around this is that people believe that having a squint eye is lucky for you. That kid doesn't believe it's lucky for him. The kid is actually struggling because they are having two different visions of two different eyes. But when you're seeing me, Dr. Pal, are you seeing one of me or two of me? You're seeing me as
just one for now, but after call, night duty too.
But genuinely you're looking at one.
Only one.
But you have two eyes. So when you have two eyes, what's happening? In the brain, these two images are fusing to form one. Problem what happens is when you have two different refractive errors in two different eyes, which are too disparate apart. One image is good and one image is bad. The brain will go through a confusion state. Hey, I don't know what's happening here. Let me shun out or black out this bad image. Let me only keep one image. And it will shut down that eye, the bad eye.
Wow.
This is what's happening in lazy eye. So between the age of 2 to 5, please get a check done for refractive error and lazy eye.
So this is like a preventive exam.
This is a preventive
So
exam.
every kid needs
Please
to get
do
this
it.
done.
Please do it because they will not know. By the time they've gone to school, it's too late. After 5 only they are going to school. Then the teacher will come and tell you he's sitting in the front bench even after I'm asking him to go into the back bench. So that means there's a very clear indication I cannot see the board.
I see.
And this is in today's world. In tomorrow's education system, we may not even have boards. We'll have only laptops. We never know. So that's where we have to have a huge sense of proactiveness to go and get the checkup done, even if there's no issue.
Let me ask you a very practical question.
Please.
Maybe it's in US.
Yes, please.
So in US, there's two different kind of ophthalmology people.
Okay.
One is the ophthalmologist, like you. You are
Yes.
a full-blown ophthalmologist where
Correct.
you do surgeries and all those things.
Correct.
The second one is optometrist.
Yes.
Optometrist.
Yes.
They are easy to access.
Yes.
Ophthalmologist appointment is 6 months from now. You have eye pain. By the time you get an appointment,
Will not get.
the eye pain will be gone.
Yeah.
So,
Yeah, absolutely. You're right.
So people go to optometrist.
Absolutely.
For these kind of routine checkups, optometrist is good enough. That's number one. Number two is in India, is it the same practice?
Not at all. In India, an ophthalmologist is very easily accessible in today's world. Maybe few ophthalmologists are more difficult than others, but you will always have an ophthalmologist ready at your beck and call at any point of time. If you walk in, they will not say no to seeing you. That's a very good thing is happening in India.
Of course.
Plus, in India, we work 6 days a week. You know that. Versus in the US, you work 4.5 days a week. So that's a big difference in terms of timelines. That being said, the regulatory system in India versus in US, it's a lot more flexible in India versus in the US or in Canada, where you have to work only these many hours if you cannot work more than a particular number of hours a week. So those aspects have definitely generated a huge sense of dependency on optometrists in the US and Canada and other countries.
Correct.
The dependency on optometrists is not so heavy here, although that trend could change in the recent or the near future. Currently, ophthalmologists are available for us at any time.
Hopefully, they should reduce their workload and increase the availability of the optometrist.
Yeah, so I think what's happening now is so much incidence on myopia, so much incidence on glaucoma, so much incidence of cataract, so much of corneal issues are increasing on the rise. Dry eyes, so many conditions that are increasing on the rise, we are going to need to
More.
extend our arm to optometrists to start serving at different places.
Correct.
Plus, if you look at the ophthalmology, the density of ophthalmologists in the urban cities are extremely high versus the rural cities are extremely low. That being said, optometrists can play a huge role in these rural pockets, at least to kind of bring forth or back the focus on awareness on eye care.
This is for the Indian community in the US, that optometrist is okay. So don't think that you need an ophthalmologist. Get all these refractive errors checked with an optometrist. Timing is critical.
Absolutely. In fact, I recommend to go to an optometrist because they have the time. They have been guided by the ophthalmologist. They have been told exactly what to do in which scenario by the ophthalmologist, and then refer them only if there is a need beyond a point.
Beautiful.
So it's a very structured program.
Beautiful. Super. So we talked about 2 to 5.
Yeah.
So this is a wonderful point that you mentioned, that any kid 2 to 5 should be evaluated by an optometrist or an ophthalmologist for refractive error. And then what is the next age group?
Next age group would be between 5 and 12. So the 5 and 12, you have to look again for refractive error for sure. You must look for any myopia progression. If there is myopia there, you can start putting them on myopia control. You can start putting them, if there is a lazy eye condition, which will come about even in 5 to 12, you still have the refractive error that goes into lazy eye or the cross-eyed. Because these kids then is when they are entering the schools, and that's when usually it is the teacher who calls the parent up and says, hey, the kid's actually sitting in front in the class, they're not going behind because of a particular reason, because they can't see the board. Or there'll be a school eye camp that's happening, and there they will pick it up. Parents are quite busy, and we also, as parent, myself, we try to avoid thinking about the problems. We kind of focus on other issues. Hey, are you studying well? Are you doing all of that stuff? And we start focusing on their health. So try and focus a little bit proactive on between 5 and 12 to check for refractive error, check for any progression of myopia. You must, if your child was insulin dependent of type 1 diabetes, please make sure that you can start focusing on that as well. So those are aspects which we'll come to.
Super. So being an ophthalmologist, what are the critical steps that you will say for a kid's eye health?
Amazing. I think those are very pivotal. Thumb rules I'll give everybody. So the thumb rule is very simple. First, look for any refractive error in the child. Go for an annual checkup. That's number 1. Second, any distance for the devices. Keep a particular distance for computers. Keep a particular distance for phones, and put protective layers on them if possible. That is 2. Third, please go in... make sure your child is doing an outdoor play at least 1 hour, half an hour a day outside. So this helps the accommodation, helps sunlight, and a lot more other aspects which are not happening with the child sitting in the house and playing on their iPads.
Wonderful.
And the 4th one is limit the screen time. Actually, I would say incentivize the child to limit their screen time and extend their outdoor play.
Beautiful. Wonderful. I'm going to tell that to my kid.
You
Let's
must.
see what he says.
You must, actually.
Beautiful. So we talked about the 12 years of age, right? How about adults? How often they should get a physical exam of the eye?
So in adults, it's a very clear nomenclature. Annually, get 1 eye checkup done. What happens in this eye checkup, right? I mean, what are we checking? We're calling you in for an annual checkup. What are we checking? We're checking for first, and I'm talking about 40 and above. We're checking for cataracts. We're checking for glaucoma signs. This is a silent killer. There will be no symptom for glaucoma, but I still need to check.
Glaucomas increase eye pressure.
One of the components of glaucoma is an increased eye pressure, although it is a multi-organ failure.
I see.
Although it is a multi-organ failure. Third, I'm checking for diabetic retinopathy in case you have diabetes. Or if you don't have, I'm going to tell you, get a diabetic checkup done. Number 4, I'm checking for any hypertension related issues.
So high blood pressure can also affect eyes.
Correct. I'm also checking for dry eyes in this. So refractive error, cataract, glaucoma, diabetic retinopathy, hypertensive retinopathy, that is basically your retina checkup, and your dry eyes.
Wow.
I'm doing a comprehensive, holistic look at your eye, and I have to do it really quick. So it can take about 1.5 hours, 2 hours to get this whole thing done. But once it's done, you don't need anything for the next 1 year if everything is checked green.
Practical question.
Yes.
You go there, they give you two options. One is you put the eye drops, get a dilated exam, or without the eye drops using the machine.
Excellent question. And in fact, today's technology has brought about a big revolution on this aspect alone. A lot of the places still do the dilated exam, and that is probably the thumb rule by far best way to do a retinal examination. In today's world, there are devices that even without a dilated exam, you can get, instead of 180 degrees, you will get a 160 degree view of the retina.
That high?
It's very, very high.
Wow.
I think there are even devices that give close to 180.
Wow.
With one single click.
That's a huge time saver.
It's a huge time save because think about it. As a practical person going to a job every day,
Correct.
If I come into an ophthalmology clinic and get a dilated exam, it's not just the 1.5 hours spent in the hospital. It's also the 4.5 hours, 5 hours after that I can't see anything.
Correct.
I can't work.
Correct.
I can't drive. I have to have an assistant to come and pick me up, or an Uber to pick me up. All these aspects have caused a huge drop in productivity at my workplace and so on and so forth. My efficiency has gone down by technology becoming better, and I'm able to do this retinal investigation through just a single click, even through not dilating. It's a huge game changer.
Nice. Thank you for that. You saved my time.
Absolutely. I hope I can save a lot more.
I get checked every year.
Oh, that's good.
I get checked every
That's
year.
great.
And there is not significant change in the power.
Yes.
But they always say something about astigmatism and
It can change.
and how about glasses? Should we have to change that every year if there is no change in the power?
No, not at all.
Not.
In fact, if I check your eye and if somebody else checks your eye, there will be a 0.25 difference every time. And that's okay. Yeah.
So
it's
when there's
interpersonal differences will be there if I check and you check, because it's a very subjective test, right? So what happens in that scenario is only when there is a progression for a year over 0.5.
I see.
And you're symptomatic to it.
Uh-huh.
If you are saying, I can see better with these new glasses, I can't see the old, that's the only time I'll change. If you're saying, I'm able to see the same, even though it shows me a 0.5, it's fine. Move ahead. Don't worry.
One other practical question, because I wear glasses all the time.
Yes, please.
Cleaning the glasses.
Yes.
I've seen many people not do it at all.
Oh, cleaning the glasses, scratches on the glasses, and then they'll say, I can't see. Obviously, you can't see because the whole glass is scratched. Please change your glasses in those scenarios. First of all, if you have scratches and if it's an old spectacle or anything, don't wear them. It's not worth it. It's not beneficial.
Because it is putting a strain on your eyes.
It's putting a strain on your eyes. And it's not allowing the right light to go in.
I see.
So when diffracted, scattered light is going in. So you're obviously going to see a lot more glare and you'll be like, I can't see very clearly. That is the cleaning the glasses. Please do it regularly. But use the right cloth. Sometimes the cloth itself is the one that's causing the scratches.
I see.
So use the they always
the
give you
microfiber cloth.
They always give you that in the box.
Correct.
So please use that one. It's always good for you.
Practical question again.
Yeah, please.
How often you should use that microfiber cloth? My microfiber cloth looks like a kitchen cleaning cloth now.
Change the cloth.
If you think it is
at
dirty.
least annually once you can change the
Okay,
cloth.
annually once.
Annually once is more than
Okay, sounds good.
So whenever you're going to the ophthalmologist for your annual checkup, cloth.
Okay, beautiful. See all these practical
It's a
questions.
very important question. No, people tend to neglect we all neglect our own health. We worry about our family, we worry about everybody else, but we don't worry about ourselves. Somebody else has to worry about us by the time it's too late. So let's start worrying about ourselves and taking care of ourselves.
See, make yourself a priority.
Make yourself a priority. Absolutely.
Super beautiful. So one most important thing that you touched upon
Yeah.
is my topic very near and dear to my heart is diabetic retinopathy.
Yeah.
So as you know, insulin resistance is rampant and many people are being diagnosed with pre-diabetes and diabetes. One thing I want my audience to understand is that diabetes is a multi-system disease. It's not only your pancreas that is not
Yeah.
secreting insulin properly. It is affecting right from your head all the way to your toes. One of the most common thing, as you know, is it is causing small clots
Yeah.
in the blood vessels. We call it as microthrombosis in
Yes.
these capillaries.
Yes.
The most common organs that is getting affected is your nerves.
Yes.
We call it diabetic neuropathy.
Correct.
And if it affects the kidneys, we call diabetic nephropathy. And the most important thing for you is if it affects the eyes, it's called diabetic retinopathy.
Correct.
Question to you is, if you are a diabetic, how often you should be checked for diabetic retinopathy? How do we know whether it is being affected?
First of all, Dr. Pal, that is such an important question. It is the third or maybe the fourth biggest problem in the world. Okay. Diabetic retinopathy. The retina of your eye is the first organ where diabetes starts showing up. So if you're going to find a sign somewhere, first, it'll be the eye.
Wow.
If you ever have gone to a diabetologist, the first thing they'll say, the minute they see you're borderline or above, go and get a eye examination done. They will ask you for a retinal investigation done. Why? Because before it reaches the nerves or before it reaches the kidney, those micro aneurysms, as you call it, thrombosis in the kidney is aneurysm in the eye.
Dilatation.
Those micro aneurysms have already started happening in the retina. So diabetic retinopathy has a very strong link to the eyes.
Wow. So in the annual checkup that we talked about, let's say the patient is not diabetic, you can see the findings and maybe raise the possibility of diabetes. Wow.
We will direct the patient in that particular direction to say, hey, that could be a diabetic case. Why don't you get a diabetic complete evaluation done? Can be both ways. They might see the diabetes and send it here. What starts from here is a journey that is at least 20 years out. The journey is that of first diet and exercise. The journey is that of constant evaluation, annual checkup for type 2 diabetes. If everything is okay in type 1, you can do it every 2 years once. For type 1, because it takes a longer time, you're also on insulin. It's a different pathophysiology for type 1 versus type 2. What happens in type 2 or type 1 diabetes? What happens in diabetes overall in the eye? The retinal blood vessels starts to secrete some of this. It starts leaking. That leak can lead to microaneurysm in the beginning, bigger clots later on, and eventually at some point, if not taken care or not controlled well with diet, exercise and insulin and other medication, if not taken care, it can lead to a complete vitreous hemorrhage, a break in the blood vessel, and it can cloud the whole back of your eye with blood. What you will experience at this point is a sudden drop of vision, which I can't see anything.
So a patient with high sugar can actually have blood clot in the eye to leading to a complete vision loss.
Complete vision loss overnight, over a matter of seconds. And that this happens if it's not taken care very well. Uncontrolled diabetes. Also, to treat this now, I have to do a proper in vitro surgery to remove that blood clot because it cannot just absorb on its own. It's the jelly of your eye does not have an escape route.
It has to be removed by surgery.
Wow. So those are some of the aspects. Vision, most cases go back to some sort of normalcy, but never the same before.
Never the same before.
Never the same again.
So being a diabetic, and you can actually lose your vision if it is not controlled.
You can lose your vision, and the very high incidence of it.
Wow.
If it's not controlled. So I definitely recommend constant vigilance constant, and don't take it lightly. I recommend everybody, please don't take diabetes lightly. It's not a disease that has a reverse path. It has only a progressive path. We can only slow the progression today. Hopefully we'll be able to come with a technology in future which will be able to resolve.
Once the retina is affected by the sugar, it is irreversible.
It's irreversible.
Almost.
Diabetic retinopathy, glaucoma are two diseases. Once they start affecting the retina, they are irreversible.
So the annual checkup, early diagnosis, prompt treatment can prevent the damage.
Prevent.
Wow.
There are injections to prevent the bleeding.
I see. Intravitreal
Injections that can prevent the bleeding, but they don't cure the bleeding once it's happened.
It's just fascinating. You take a small injection, get deep into the eye, and you inject. Wow.
You go close into the vitreous jelly or the back of the eye and inject with the diffusion that goes. And what is it basically? It's basically anti-VEGF. VEGF is vascular growth endothelial factor. This factor, vascular growth endothelial factor, is released from the eye because there are areas of hypoxia.
Decreased blood supply.
Decreased oxygen supply to the retina. Because this oxygen is less in those areas, vascular growth endothelial factor sets in and starts creating abnormal vessels.
Blood vessels. Let me backtrack. It's a very important point.
Very important.
So you said, let me just backtrack to summarize.
Yes.
High sugar in diabetes, decreased blood supply to the eye. It causes small dilatations of the blood vessels called microaneurysm. And because of the microaneurysms, there is decreased oxygen supply to the eye. And eye is thinking that the eye needs more oxygen. So they're secreting this factor called VEGF. VEGF, vascular endothelial growth factor.
Vascular growth endothelial factor.
Vascular growth endothelial factor. That stimulates more blood vessels. Trying to stimulate more blood vessels to give more oxygen. But what is happening is the blood vessels are not formed properly.
These are abnormal vessels. They are brittle in nature. So they break and they cause bleeding.
And that is why it's absolutely important to check.
And that's why we have to be very careful. Stop that vascular growth endothelial factor. Stop the blood vessels. Even if the area is hypoxic, it's fine. Don't cause me bleeding because my central vision is very important for this patient. So although it's not a cure, it's a prevention from a bigger disaster.
Okay, symptoms. So we talked about diagnosis. So we talked about every patient who gets an annual checkup, we could figure out whether the patient is diabetic or not. And the patient has diabetes, you go and check with an ophthalmologist to see whether retina is involved. What if a patient has not seen an ophthalmologist and the patient is a diabetic? What are the symptoms will happen when the diabetic retinopathy sets in?
So the first symptom will be that of halos and glare around lights. Around lights, you start seeing some halos and glare. The second symptom you'll see is sudden vision goes up or down through the day also. If there's fluctuation in vision, this happens because of edema. As I told you, dilation is happening of the vessels. That means the retina also can dilate and go down.
So it swells up.
Especially in the fovea, the central area of the macula. Central retina. That retina can swell up and go down through the day. That should be a sign for you to say that, hey, there must be some problem here. Let me go and investigate. So these are a couple of things: colored halos, glare, vision disturbances through the day, or fluctuation of vision through the day. Although these can be very misconstrued in, this can be cataract, it can be glaucoma, it can be so many other things. That's why, to easen it out for everybody, just come for an annual checkup. We'll know what happened. If you are a diabetic, come immediately at that time to get it checked up, and from there, do an annual checkup.
Can you describe a patient experience that you had with the diabetic retinopathy? Because I really want my audience to observe it and get registered.
So a typical diabetic retinopathy patient will come to me probably in the first year of understanding or knowing, okay, I have diabetes. I've come to you. And next will come to me annually for, let's say, 3, 4, 5, 10 years. Will constantly keep the checkup going. They will drop the ball at some point and say, hey, I can't keep on doing this. And at that point is when the diet has gone off. They're not taking the medication. They're not doing the insulin if they've been told to do insulin. And now it's become from controlled diabetes, it's gone into an uncontrolled diabetic status. They've not met me for 3 years. Suddenly they'll come and call, somebody will call and say, hey, remember this patient? He came 3 years back, is now coming back, coming today because he can't see anything.
Wow.
So I'm looking at the Kishi, I'm saying, okay, this is 2 plus 2 is equal to 4. This is going into diabetic vitreous hemorrhage. This is a proper diabetic retinopathy case, which has gone into vitreous hemorrhage.
Wow.
We do a surgery on the eye to basically remove the blood clot from behind the jelly of the eye. Once that's cleared up, we push in some anti-vascular growth endothelial factor. And that hopefully should resolve the problem in the next 3 to 4 weeks. It takes 3 to 4 weeks for it to resolve. They should be back to normal. Having said that, at this time, we also start analyzing a few different things because there's blood has already gone in. We also have to be worried about cataract. We also have to be worried about glaucoma in these cases because that can be a adjuvant to the problems that can come with these patients.
Wow. And also an important lesson for other people who are diabetics is if you control your sugar levels, if your A1C level is less than 5.7, the likelihood of diabetic retinopathy progression is almost zero.
Yes. Yes.
So that's a major treatment.
That's a huge one. In fact, I'll go back to what I had said earlier. Have a balanced diet, put in your supplements, make sure you're on the medication, which is where all of this is all about. Get a holistic picture in. Now start treating the particular conditions as is. What is happening.
Correct.
So you said, get your HbA1c because the particular condition here is diabetes.
Yes.
Get your HbA1c under the 5.7 rate and you'll be fine.
Right.
The HbA1c is a very simple measure of giving you the 3-month window of what's happening.
Same thing will go with blood pressure as well.
Same thing goes with blood pressure. In blood pressure, it is a little less dramatic.
Less dramatic.
It's still serious.
Severe, but not less.
But it's not as dramatic as it would be in this.
You call that as hypertensive retinopathy.
Yes, hypertensive retinopathy.
Is that reversible?
None of these are reversible.
None of these are reversible. Once the damage is done.
Once it's done because, see, you can reverse a blood vessel from going through damage. You can reverse a skin tissue from going through damage. Epidermis, dermis, liver, all the cells can go through reversal. The nerve cell once affected can never go into reversal.
Wow.
So what is the retina? We're coming back to the retina, right? Retina is the extension of the brain.
Wow.
So it's a nerve cell.
Nerve cell.
That nerve cell can never go back.
So retina is golden.
Retina is gold. You have to preserve it. What's happening in diabetic retinopathy, in hypertensive retinopathy, in glaucoma is nerve damage. That's why you can't go back.
So hypertensive retinopathy can happen if the blood pressure is more than 140 or even between 120 to 140, stage 1, stage 2 hypertension as well.
Hypertensive retinopathy can happen even in normal tension. So for that particular patient, that pressure is high.
For the eye.
For the eye. And at this point, I want to segue into also explaining hypertension versus... I want to give...
Go ahead. That's okay.
I want to segue into explaining what is hypertension, that is blood pressure, and glaucoma, which is eye pressure. Everybody's confused about this topic.
Please.
It is a very big topic. The blood pressure, if high, need not be that eye pressure is high as well. The eye pressure can be normal. When the blood pressure is normal, the eye pressure could be high. They are two different diseases having two different pathways. Hypertensive, I'll avoid talking about it, but let's take glaucoma. Eye pressure, whenever it's high, what's happening? There are two main reasons why glaucoma sets in. One is too much production of aqueous, too much production of fluid inside the eye. So your balloon, eye is basically a balloon. It's distending beyond its need. Okay. Second is obstruction to the drainage. So it's not draining enough fluid out. There's inflow and there's outflow. Either of these two only is happening.
More inflow, less outflow.
Or correct inflow, less outflow.
Less outflow.
Whichever way, the balloon is distended.
Distended.
When the balloon is distending, it presses upon the retina. The retina is the extension of the brain. Nerve cell, press.
So the brain doesn't like it.
No,
The
brain
nerves.
doesn't. This nerve, if it presses, 1 day, 2 day, no problem. 6 months, 1 year out, the nerve starts to die. I can't take this anymore. One by one, those trillion neurons starts coming down. Those trillion neurons, they start dying. They start dying from the periphery and then come to the center. That's why you start losing the peripheral vision first, and then you lose the central vision. Eventually, you'll be left with tubular vision. So you can only see me. You can't see around me. Right now, if I extend a slap to you, you'll see my hand coming and you can protect.
Correct.
Or when I'm walking down steps, I can see the steps even if I'm looking straight. Because I know there are steps. So what happens in the signs and symptoms of those glaucoma in advanced stages, not even early stages, nothing. Only in advanced stage, they'll start tripping over
While
footsteps.
you're walking down the stairs. So tripping down the stairs.
They'll not be able to see a rod on the side. So they'll bump their head on the rod because they're only seeing straight. They're not able to see. Or they'll not be able to play a sport which needs peripheral vision.
The other common problem is glaucoma, increased pressure in the eye, right? So what are these signs and symptoms of glaucoma?
So the signs and symptoms of glaucoma are very simple. It follows the same pattern as any nerve damage does. So colored haloed around lights, blurring of vision. You also have, in advanced stages, you will have peripheral vision coming down into a tubular vision.
You can just see
So
straight.
you can only see this portion. You can only see me. You cannot see what's happening around me. You cannot see Dr. Pal's gut feeling. You'll only be able to see me. This is in the advanced stages of glaucoma. So these are some of the signs and symptoms of glaucoma. That's why before it reaches this stage, because at this tubular stage, nobody can do much. We can only preserve this. Maybe. We can't bring back what is lost. But had I found out that at this stage I'm losing vision, peripheral vision, I can stop the progression of this disease there. There are multiple things I can do.
Okay.
There's medication I can give.
Eye drops.
Eye drops. There is stent surgery that I can do.
Wow.
Or it's called as micro-invasive glaucoma surgery. Keyhole to the surgery, come out, extends or slows the progression for 3 to 5 years. Next, drainage. I'm increasing the drainage. What is the problem? Distension. So I want to increase the drainage. So I'm increasing the drainage of the aqueous, or the production of this aqueous is drained out of the eye. That is the third. When it becomes extremely severe, I put a tube or a shunt to express a lot more fluid.
Wow.
So there are 4 stages at what I can do. All of them are only to slow the progression of the disease, never to reverse what damage is already caused.
I see. When you do this, you'll be able to see all these findings early stages during their annual checkup?
Yes. We should be able to do a complete glaucoma workup if found to be any of these.
I see. During the annual checkup?
During the annual checkup.
Okay.
I'll give you simple 3 or 4 things that we do in glaucoma checkup, which is important. We do a pressure check. We do a visual field analysis, not vision, visual field. So the field of vision is what we are checking. Third, we're checking the retina nerve fiber layer.
I see.
Straight. We want to hit and see how much retinal nerve fiber is alive and how much is dead.
Wow.
Fourth, we're taking an image of this retina.
As a
to keep
baseline.
As a baseline. So I can compare what's happening.
Because
Because most of these people will also have other conditions with
Correct.
this involved.
Correct.
It could be cataract, it could be diabetic, it could be hypertension, it could be cornea issues, it could be the multiple factors. As I said, glaucoma is a multi-organ disorder within the eye, not outside the eye.
Right. So along the same lines,
Yes.
we'll talk about cataract.
Sure.
So cataract is very common.
Yes.
And with my understanding, I'm thinking that lens, as you talked about, cornea and lens should be transparent,
Yes.
where the light should go in
Absolutely.
and light should come out.
Yes.
So cataract is happening where this lens is being accumulated with these proteins, and that is causing an opaque lens. Correct?
Absolutely. Clouding of the lens happens with age. It's basically, in today's layman terms, graying of the hair, graying of the lens. Think of it like that.
I see.
Can I reverse it? I can put a dye, but I can't reverse it. So inside, I can't put a dye, and I want it to be transparent. So it's becoming opaque very gradually. When it's happening very gradually, what's happening is the patient or the person doesn't know that my vision is coming down, because it's so gradual over 5 years, 10 years. How will I know? I'll forget. I'll keep thinking this is normal. Every day I wake up, this is normal. This is normal. So it becomes a way of life. It is only when I do one eye of the patient will he realize, oh my God,
not able to see.
I'm able to see now after the surgery is done. Now the other eye needs it because I can't see with the sign. The colors start coming in. The brightness is back again. So the patient's able to start seeing again.
So graying of the hair, example.
Yeah.
So it happens uniformly on both sides?
Yes. In 95 to 98% happens both eyes.
It's bilateral.
Always. In 2%.
The severity differs.
Severity may differ. It may happen. In 2%, congenital cataracts, it can happen in unilateral. If it is related to a condition like a systemic condition, usually happens both eyes, but sometimes can happen in one eye. If you have a deformity in one eye, like a coloboma or something like that in one eye, you can have in one eye.
But in general, it's
trauma
bilateral.
Can occur in one eye. Any of these, generally it is both eyes.
Bilateral. And the symptom is, decreased vision.
Decreased vision is the only symptom in cataract.
In the cataract. So my dad had cataract.
I just wanted, cataract per se need not decrease vision. My cataract is growing, but my vision is great. I'm able to see the last line on the board. Cataract alone is not vision loss. Vision loss can be formats, right? There can be the board that we all talk about.
Yes.
But there's also contrast. There's quality of vision that goes down.
I see.
So the black and white hues go down. So there are a lot of other tests that we do. And in interest of not confusing the audience, I'm going to stay away from actually explaining that. But there are multiple tests that are done for cataract evaluation that define how bad or how severe your cataract is. It need not be vision loss.
I see.
Although vision loss is 80% of it.
I see.
15% is something else.
The reason I'm asking is my dad had vision loss.
Right.
Okay. But he was able to do
Read
normal
everything.
activities, everything. So when we pushed him to get the surgery done, he said, no, why am I doing it? I'm doing okay. When I will get to that stage of I'm not able to do my daily activities, I'll get the surgery done. It's a very common thing among people. Very common. Is that right or wrong?
I think it's one of the most important questions you've asked, because cataract is the number 2 cause of blindness in the world, after refractive error, of course. So let's dig deep into this. Okay, that is probably right if you were 30 years back, when the machines were not as good, when the intraocular lenses were not that well advanced, when the sophistication and the skills required for cataract surgery were not that good. In today's world, if you want to lead a quality-driven life, that is completely the wrong thing to do. Just think about it. Machines, IOLs or intraocular lenses, and the skills of surgeons have gone
Exponentially.
Spellbound. They've gone exponentially high up.
Higher.
But the quality that is required, that is when I'm doing a hard cataract. So in those scenarios, I have cataract. My vision's good, but my cataract's growing. If my cataract's growing, what do I do to remove any cataract? I do ultrasonic energy. I'm doing ultrasound energy to remove the cataract. The amount of energy that I need for dissolving a soft cataract versus the amount of energy that I need for dissolving a hard cataract is very, very different and very high in hard cataracts. So along with removing cataract, I'm also causing damage to other structures in the eye.
I see.
This ultrasound cannot focus only on the cataract. It's still a machine. It's still there. It's causing damage to other things. Bring out the cataract at an optimal time. I'm not saying when you find out.
Correct.
But 6 months to 1 year out, take it out. There is no purpose of that lens. Think about it. The lens has a purpose till the age of 40. After the age of 40, presbyopia sets in. Your accommodation of seeing far and near is starting to go down. By the time you're 50, it's pretty much gone. There is no purpose for that lens to be there anymore. Take out that lens, put an artificial lens, which will now be there for life. These artificial lenses are made with 150-year life expectancy.
Longevity, I see.
Nobody's living that long, at least now. So we shouldn't be too worried about it.
I see.
That's the way to look at it, very systematically or if you want to put a method to this madness, this is how probably you should think about it.
Beautiful. So relatively earlier the better.
Relatively earlier the better.
To prove, so that the outcome is better.
Absolutely. The later you do it, the energy is too high, the type of procedure done is different, and a big aspect, it can suddenly in 1 year become hyper mature and burst also.
Wow.
That cataract can burst and it can drop the lens. Then I have to do a complete different procedure for that complication of that cataract.
Wow.
Yeah.
Recommended to do both cataract at the same time?
Not on the same day. 1 day or 2 days apart.
2 days apart. Okay.
Yeah.
Because recovery is pretty fast.
Yeah, much fast.
And can you just tell me the actual surgical procedure? Briefly.
Yeah, I will. For sure. So we basically make incisions. There are 2 small incisions, about 2.5, 2.8 millimeters.
Small knife.
Small knife. Small
which
blade.
area?
On the cornea.
On the cornea. Above.
On the cornea above.
Above.
Not in the center, above.
Just below the eyelid.
Just below the eyelid, on the black of the eye, just at the edge of the black.
Wow.
Edge of the black, you make an incision.
Anesthesia is?
I pretty much do topical, so I just put drops and
drops in this.
You don't even
anesthesia.
Need local, nothing.
Okay.
Put drops and go ahead.
Okay.
So make an incision. The cataract itself is inside a bag. It's inside a bag. I have to make a circular opening on the bag from above. Okay. Once I make that circular opening, I get access to the cataract. I pull out the cataract and start emulsifying it using a ultrasonic probe. An ultrasonic probe goes inside, emulsifies, liquefies that cataract and brings it out.
The plaques kind of thing.
The plaque. The whole cataract is one big chunk. It just comes out after breaking and aspirate it into this probe. Once that is cleared up, I put an intraocular lens inside the bag. Inside the bag.
Lens?
Yeah. This bag now holds that intraocular lens in place for life.
Because all the debris has been removed.
All the debris is removed. It's a clear zone. All I have to place is an intraocular lens. I close up.
Wow.
And no sutures, nothing.
It just heals on its own.
It heals on it because it's a small incision.
Yeah.
Earlier, back in the day, we used to say, and this is a myth, because I'm trying to break a myth as well in cataract. Oh, let the cataract become ripe. Let it become mature. Let it wait. Wo motia they say in Hindi.
Motia, yes.
So let it become ripe. Let it become hard. Then we will do the surgery. The surgery was very different then. We used to do half the eye used to be opened.
Wow. More aggressive.
Very aggressive. About 12 millimeters of the eye used to be opened. And this whole big thick nucleus used to come out.
Wow.
And then you place a lens and put sutures.
Wow.
Gone. Gone are those days. 99% we don't do that. Yes, we do it. We do it in specific
cases.
scenarios.
How long does it take?
Phaco, I mean, this procedure which I just explained usually takes about 10 to 15 minutes in an average surgeon's hand. And a good surgeon will probably take 5 minutes or less.
That's why all these eye cams are so successful.
Yeah.
Right? You guys are doing so many good eye cams.
Yeah.
You major institutes.
See, even with the number of eye cams we are doing, I still feel we're doing low.
Wow.
Because the number of people that need vision restoration with cataract is so high. Not a single person will go through life without having cataract.
It's based on the severity.
It's just based on
Based on
they
severity.
will,
So you will get it.
have it. There is no way you cannot have it. Anybody above 50 already has it, is either not gone to the doctor to check up or is choosing not to do it. Whichever one.
I see. So you will get it. It's just based on the severity.
Yeah, you will get it.
So what are the things that we could do to prevent cataract as much as possible?
To prevent cataracts, you can do 4 things. First, start wearing sunglasses, the UV filtered sunglasses. Second, start having foods that are rich in antioxidants. Third, start doing blue light filtered device protection, whether it's laptop or computer screens. And fourth one, please stop smoking. Because no matter what you do, smoking is very detrimental. Overall health, including cataracts.
Smoking is directly linked to cataract.
Directly linked to cataract, absolutely.
Alcohol?
Alcohol occasionally is okay. But excessively or doing it too frequently can both be harmful to you.
Okay. If I do a cataract surgery, will that ever recur back again?
Oh, it's a brilliant question, because a lot of people, and even on your Googles, when you do, cataract regression, the concept of cataract coming back does not exist. Yes, there is a small film that can grow on the posterior capsule of this bag that I explained. There's a bag, I place the lens. On that capsule, there can be a film that can grow. That film does not need a surgical intervention from outside. It needs only a laser shot. That's more than enough to open up that bag and allow you to see again. This, unfortunately, cannot be predicted before the surgery. This can only be... There is no way I can cut your skin and say, now I'm doing trial and error in the eye. There's no trial and error. So what I'm doing now is, I'm doing the cataract surgery, I'm placing the lens. In case you get a PCO, it's called posterior capsular opacification. If you get a PCO, all I'm going to do is shoot a laser, it'll open up that bag and you will be able to see again.
I see. But not that common.
Not common.
Not that common.
It's about 5 to 7%.
7%.
But that is quite heavy.
Given the number of people.
Given the number of surgeries that you're doing, the absolute number can look quite big. But it's easily treatable.
It's easily
Don't overthink it.
Yeah.
Your cataract will never grow back.
Okay. How many cataract surgeries do you do per year?
I do close to about 2,500 a year.
Wow.
Yeah.
Wow. That's much amount of
that
requirement
is the
there.
amount of requirement.
Wow.
That
Okay.
is.
Beautiful. Wonderful discussion. So we're going to wrap this up by talking about some myths.
Of course.
Surrounding eye
Of
health.
course,
Okay.
yes.
So I'm going to open up.
My favorite section.
Okay. The first myth is people who are colorblind will see in black and white.
That's a complete myth. Even if you are severely colorblind, you will still see some amount of color. The most abnormal form of color blindness, even they see in shades of grey but with a little tinge of colors. We're playing with hues here. We're not playing with absolute colors, but we're playing with hues. That's what we have to remember in color blindness.
Super. If you cross your eyes, they may stay that way permanently.
It's a myth. But I don't recommend doing it because it causes a lot of digital strain to the eye. You're always in a flexion mode. So don't do it too often. If you're playing around, it's fine, but not on a general note.
But there are some people who can rotate their eyes.
No.
I mean, not rotate the eyes.
Their eye oscillates.
Oscillates.
So when their eye oscillates, it's a specific condition called as nystagmus. It's not, they're not trying to do it. It's just happening. In fact, I get so many Instagram DMs. Hey, I'm having nystagmus. Can I do something about it? It's unfortunate we can't do anything about the nystagmus per se, but we can do anything related to it. So they can have nystagmus with a cataract. We can have nystagmus with a swim. We can take care of those even in nystagmus patients. It's not like it's a contraindication for me not to treat those people.
Got it. Okay. The third thing, very important thing.
Yes.
My friend Saranokuma thinks that if you grow more on social media, people will cast an evil eye on you.
I think it's true.
Evil eye concept is very, very rampant.
It's pretty rampant in India, and we have to to answer these questions as well.
Anyways, the last one is drinking lots of water helps your eye. Myth or truth?
I think there's a truth in that. It definitely keeps your eye hydrated. It keeps your tear film aqueous production high. Excessive water, again, abundance of water has no relevance or no scientific evidence to prove that it will keep it like that for life. So if you have a genetic condition like a Sjogren syndrome, or you have a chromosomal abnormality of having dry eyes, it's not going to solve by just having a lot of water. That's a problem in the system that needs to be corrected systematically. But having less amount of water can harm your eyes by having dry eye syndrome, leading to myopia, leading to scratching, itching, rubbing, keratoconus. That trend is a vicious cycle.
And for dry eyes, before coming to an ophthalmologist, if they have to treat symptoms, they can do artificial tears.
So
like
this is in India, it's a road on thin ice.
I see.
Because you go to a pharmacist, the pharmacist is going to give you either he'll give you a proper lubricating eye drop. Sometimes they suddenly give a steroid eye drop.
I see.
That steroid used prolonged will start causing a drop in immunity of your eyes. You'll suddenly get an infection, viral, bacterial, fungal. And then you'll be like, hey, how did this happen? So it's a very thin road on thin ice. Get a consultation and then do whatever has to be done.
So eye drops should not be steroids.
Definitely don't put steroids unless a doctor has prescribed that.
Similar to an antibiotic.
Absolutely. There are combination of antibiotic with steroids. Eye drops. Those also have to be prescribed.
So not all eye drops are same.
Not at all. No, the bottle looks the same, but they are completely different molecules.
Of course.
There are billions of dollars being spent on on these research of these products before they come out.
Got it. And people say that as a man, you should not cry because your tears should not come out.
No. Men cry more than women nowadays.
Tears is a good thing.
Tears is a good thing. Tears is a good thing.
It is.
Absolutely.
It helps you.
In my field.
In your field. If you are actually crying a lot with tears, it's actually a good thing.
It's a good thing.
Super. Wonderful. Thank you again for your wonderful knowledge and your time. I'm hoping that, people get one or two things that they can implement on their daily practice.
I always tell, 1%, if anybody takes 1% of this video, I think it's a huge benefit to both of us and the community.
Beautiful. Sounds good. Keep up the good work.
Thank you.
Agarwal Eye Institute.
Yes.
Please check that out. And looking forward to have more chat and conversation like you in future. Thank you for your time.
Thank you, Dr. Pal. And we are all so looking forward to all what you've been doing. The podcast is one, but you also have multiple others things coming out. And so excellent work that you're doing.
Sounds good. Thank you so much for your time.
Fantastic.
Thank you. Bye.
Thank you.